Hello, everyone. My name is Tanner Hoodery, and today I'm going to be discussing the 3 journal articles for the online Health 101 class here at Lake Superior State University, Medical Terminology. So we had the option of doing 3 articles on one subject or 1 article on 3 different subjects. So I wanted to do the 1 article on 3 different subjects just because I like to learn more about different things. So in terms of what I chose the musculoskeletal system, but more specifically, I'm going to classify it as the muscular system. The next one will be a endurance one, so it'll be relating to the cardiovascular system, and then the last one will be relating to the skeletal system. So for the first journal article that I found, I wanted to research turf toe injuries, just because I had one when I was in high school, and I just want to learn more about it. So basically, what a turf toe injury is if this was my foot, it's when this joint, but in the foot it'd be the metatarsal phalangeal joint. It gets hyperextended. So most of the time you'll see it if the toe is planted and then a force is applied to the heel of the foot downward, thus hyperextending that joint. It was first described in 1976 by Bowers and Martin at West Virginia, but it's been a more increasing injury because of the artificial playing surfaces such as turf and then more flexible footwear as well. In this article, they discuss a little bit about the epidemiology. So 0.062 per 1,000 athletes are subject to turf toe injuries, with an average of about 10 lost days due to the injury. So it's pretty substantial, even though it doesn't occur as much. But there was a survey done once by Rodeo et al., and there were 80 active professional football players. Out of those 80, 45% had suffered turf toe injuries in their career, with the majority of that being on artificial turf. So nowadays, they're attributing it more to the flexible and lighter shoes and changes in that surface and cleat interaction. So I discussed the mechanism of injury, where it right on the plantar plate on the plantar side of the foot, which is the bottom side of the foot, hyperextends. Obviously, it's very debilitating and it's very painful. It stretches the flexor hallucis brevis tendon, and then there's also 2 sesamoid bones that kind of would be just like that on the big toe. A lot of times they are separate, but sometimes they are seen to be fused together in just very, very few cases. And so basically it impairs that tendinous sesamoid complex. You see a lot with the grade 1 strain. There's only just a sprain, just maybe a few micro tears to that ligament. In a grade 2 sprain or a grade 2 turf toe injury, there's a partial ligamentous tear. And then with a grade 3, it's a complete ligamentous tear. The tendon is completely severed. So, in order to manage the treatment, there are non-operative ways and operative ways. So for the non-operative treatment, a grade 1 injury isn't that debilitating, isn't that great of an injury to where they're going to have an extended loss of playing time. So basically a stiff-soled shoe with potentially a plate insert or an orthotic to limit the flexion of that big toe. Grade 2 injuries, you can see them potentially using like a walking boot and for protected weight-bearing purposes. And then they can also progress into non-weight-bearing activity or low-impact exercise, such as like bicycling, elliptical training, or hydrotherapy, where they'd be like walking in a pool where they have part of that weight counterbalanced. And then a grade 3 would be the longest. It says may require up to 8 weeks or longer of recovery, and specifically immobilization. And then surgical treatment. this seems to be the lesser of the two evils here, as it would potentially prolong that recovery time. So, in conclusion, turf toe is rare, but it's still a very debilitating condition. Um, so, yeah. Now, the fun fact that I learned was the two sesamoid bones generally shift when the toe is contracted or flexed and extended. And so a lot of times they'll see in the turf toe injuries, it'll have slightly less movement than with a regular toe functioning normally. Next one was relating to the long-term effects of aerobic endurance on cardiac structure, stroke volume of the left ventricle, and cardiac output. So in this study, it was an experimental study, and they had 22 volunteers, including 10 people who have continued regular exercises and 12 people as a control group. So basically, what they ended up doing was with the two groups, they both were doing the same exercises and then just compared as far as their cardiac structure and then stroke volume. So basically, the program consisted of a 10-minute warm-up and cool-down consisting of stretching, but then the main exercise done in between was about 40 minutes in length. It was at 60 to 70% of their heart rate reserve, or an RPE, or rate of perceived exertion, between 11 and 13, and then kicking that up to the next half to an RPE of 13 to 15. So they're doing this hour-long program 4 times a week, and then in the long run, they're just seeing how they differ at the end of the survey, or at the end of the experiment. So what ended up being proven was there was significant differences in groups with the left ventricular end diastolic volume, left ventricular mass, and left ventricular mass index per body surface area. However, in cardiac function, only left ventricular stroke volume showed significant differences between groups. So there was a lot more difference shown between the structure of the heart and between the structure of the heart and then the function of the heart. Then in the last one, the scaphoid fracture in an athlete. A lot of times you see this happen when an athlete or someone falls on an outstretched hand, because this is the scaphoid bone right here. So when that hand is fully extended to try and break that fall, that scaphoid bone is completely susceptible to an injury. So this is a tricky injury because there's not a lot of blood flow to the area. Only certain ways that the fracture occurs allows for greater blood flow. So it actually says here, the scaphoid is the most common carpal bone fracture in athletes and accounts for up to 70% of all carpal bone fractures. It says males between ages 20 to 24 are associated with a higher rate of scaphoid fracture, which I actually believed it would be more high school, just because a lot of high school athletes fall on the outstretched hand. I know I did when I was in basketball and football or whatever, but specifically with basketball, you see a lot of falls to the floor where you see that impact to the wrist. So I thought that was kind of unique. I was kind of surprised that it was the more college-aged rather than high school. But in this, they talk about the anatomy. But basically, the essential thing is that the scaphoid bone is here, that there's 7 other carpal bones, but the proximal row of the wrist is the most commonly injured. Also, there's different types of fractures. So type A fractures are acute scaphoid fractures that are stable. Type B scaphoid fractures are considered unstable and are divided into different groups. And then type C scaphoid fractures describe a delayed union. So basically, when the fracture splits the bone, the delayed union means the fusing or the refusing back together. So for this one, they talked about treatment as well in this one, comparing non-operative versus operative treatment. in this one, they actually prescribed the operative treatment to return to play or return to normal activities sooner. So they described, in this instance, they described military personnel. So they said they discussed the scaphoid fractures in military population, which is similar to the athletic population, just based on the stresses and demands that the military personnel has to go through, as well as the athlete. So patients were either treated with cast immobilization, so just basically here and then around, or a screw fixation, so internal reduction, open reduction, internal fixation. And says those who had surgical intervention returned to military duty 7 weeks quicker than the non-operative group. And then the operative group also had radiographic evidence of union 8 weeks sooner. So at the 2-year final follow-up, there was no difference, but they were still able to do the same activities sooner, even though 2 years down the road, there was no difference in the wrist range of motion or in grip strength. So I thought that was kind of unique too. Sometimes surgeries, they can take longer. Most of the time they do take longer. So I figured that was kind of my interesting fact on this one, is that the surgical group actually provides better outcomes for quicker results than the non-operative group. And then my interesting fact that I learned was that the heart also can obtain greater mass. And for this one, it seemed a bit more significant than I would expect, just because it would increase by, let's see, even 0.3 millimeters, which is, to me, seems quite significant, just because there's only so much room available for the heart to grow. So if it gains that also in the other areas of the heart too, it just becomes larger and larger and thicker and more strong. So I just found that to be kind of unique as well. So those are my 3 articles. I apologize for the length of this video. I recognize that it's pretty long, but thank you for sticking through. I appreciate it, and have a good day.